Welcome to Pediatric Case Review. I'm delighted to present this comprehensive lecture on mucopolysaccharidosis or MPS disorders. This lecture is designed specifically for healthcare professionals, including physicians, genetic counselors, and specialists who manage patients with these complex lysosomal storage disorders. Today we'll explore the genetics, pathophysiology, clinical presentations, diagnostic approaches, and management options for MPS disorders. Less than number, greater than number. Let's begin with our first question about MPS pathophysiology. Which of the following best describes the primary pathophysiologic mechanism in mucopolysaccharidosis? Is it A, defective glucose metabolism, B, impaired glycosaminoglycan degradation, C, abnormal amino acid transport, or D, defective lysosomal enzyme activation? The correct answer is B. Mucopolysaccharidosis are characterized by impaired glycosaminoglycan degradation. These disorders result from deficiencies in specific lysosomal enzymes needed to break down glycosaminoglycans, formerly called mucopolysaccharides. This leads to progressive accumulation of these substances in various tissues and organs, causing multisystemic dysfunction. Each MPS type has a specific enzyme deficiency affecting particular glycosaminoglycans. Moving on to our classification question, how many distinct types of MPS disorders are currently recognized? Is it A, 4, B, 7, C, 11, or D, 15? The correct answer is B, 7. There are 7 main types of mucopolysaccharidosis disorders, numbered MPS 1 through MPS 9, with some numbers no longer in use. These include MPS 1 or Hurler syndrome, MPS 2 or Hunter syndrome, MPS 3 or Sanfilippo syndrome with 4 subtypes, MPS 4 or Morquio syndrome with 2 subtypes, MPS 6 or Maroteau-Lamy syndrome, MPS 7 or Sly syndrome, and MPS 9 or hyaluronidase deficiency. Let's test your knowledge about MPS inheritance patterns. Which of the following MPS types has X-linked recessive inheritance? Is it A, MPS 1 or Hurler syndrome, B, MPS 2 or Hunter syndrome, C, MPS 3 or Sanfilippo syndrome, or D, MPS 4 or Morquio syndrome? The correct answer is B. MPS 2 or Hunter syndrome is the only MPS type with X-linked recessive inheritance. All other MPS types follow an autosomal recessive inheritance pattern. This explains why Hunter syndrome predominantly affects males, while carrier females typically show no symptoms or mild manifestations. Hunter syndrome is caused by mutations in the iduronate 2 sulfatase gene located on the X chromosome. Let's examine our first clinical case. A 2-year-old boy presents with coarse facial features, hepatosplenomegaly, and corneal clouding. His parents note developmental regression starting at age 18 months. Which MPS type is most likely? A, MPS 1 or Hurler syndrome, B, MPS 2 or Hunter syndrome, C, MPS 3 or Sanfilippo syndrome, or D, MPS 4 or Morquio syndrome? The correct answer is A, MPSI or Hurler syndrome. This classic presentation includes early-onset coarse facial features, corneal clouding, hepatosplenomegaly, and developmental regression. Corneal clouding is a distinctive feature of Hurler syndrome not typically seen in Hunter syndrome. MPS 3 primarily affects the central nervous system with milder physical features, while MPS 4 predominantly causes skeletal abnormalities with normal intellectual development. Let's discuss general examination findings in MPS disorders. Which of the following is not a common general examination finding in most MPS disorders? A, short stature with disproportionate body, B, coarse facial features, C, normal intelligence, or D, joint stiffness and contractures? The correct answer is C. Most MPS types involve cognitive impairment, except for Morquio syndrome, which uniquely features normal intelligence despite severe skeletal deformities. Common findings across MPS disorders include short disproportionate stature, coarse facial features characterized by large head, frontal bossing, depressed nasal bridge, thick lips, and prognathism, as well as joint stiffness and contractures. Developmental delay and cognitive regression are hallmarks of many MPS types. Regarding dysmorphic features in MPS disorders, which constellation of dysmorphic features is most characteristic of MPS disorders? A. Microcephaly, thin lips, and hypertelorism. B. Coarse features, depressed nasal bridge, and thick lips. C. Low-set ears, micrognathia, and epicanthal folds. Or D. Elongated face, high-arch palate, and arachnodactyly. The correct answer is B. The classic dysmorphic features of MPS include coarse facial features, depressed nasal bridge, and thick lips. This characteristic facial appearance, often called gargoylism in severe cases, results from glycosaminoglycan accumulation in soft tissues. Additional common features include macrocephaly with frontal bossing, prognathism, hearing loss, and corneal clouding in most MPS types except Hunter syndrome. Upper airway obstruction and chronic nasal discharge are also frequently observed. Let's consider another clinical case. A 6-year-old boy presents with behavioral problems, sleep disturbances, and mild coarse features. He has no corneal clouding or significant skeletal abnormalities. His developmental milestones were initially normal, but is now showing regression. What is the most likely diagnosis? A. MPS 1 or Hurler syndrome. B. MPS 2 or Hunter syndrome. C. MPS 3 or Sanfilippo syndrome. Or D. MPS 6 or Maroteau-Lamy syndrome. The correct answer is C. MPS 3 or Sanfilippo syndrome. This condition is characterized by predominant central nervous system manifestations with relatively mild somatic features. Sanfilippo syndrome typically presents with behavioral problems, hyperactivity, sleep disturbances, and developmental regression after a period of normal development. A cherry red spot may be observed on fundoscopic examination. In contrast, MPS I and II typically have more prominent physical manifestations, while MPS 6 preserves intelligence. Regarding skeletal manifestations in MPS, which skeletal manifestation poses the greatest risk for acute spinal cord injury in MPS patients? A. Kyphosis, B. Scoliosis, C. Atlantoaxial instability, or D. Gibbous deformity? The correct answer is C. Atlantoaxial instability is the most dangerous skeletal manifestation in MPS patients as it can lead to spinal cord compression and sudden neurological deficits. This condition requires careful monitoring, precautions during anesthesia, and sometimes surgical intervention. Other common skeletal manifestations include kyphosis, scoliosis, gibbous deformity, joint stiffness, and contractures. MPS patients often undergo multiple surgeries for complications like carpal tunnel syndrome due to glycosaminoglycan accumulation. Let's discuss diagnostic testing. Which test is considered the gold standard for confirming a specific MPS diagnosis? A. Urine glycosaminoglycan quantification. B. Enzyme activity assay in white blood cells. C. Clinical examination and radiographic findings. Or D. Genetic testing for known MPS mutations? The correct answer is B. The enzyme activity assay in white blood cells is the gold standard for confirming a specific MPS diagnosis by identifying the exact enzyme deficiency. The diagnostic approach typically begins with urine glycosaminoglycan analysis as a screening test, followed by enzyme assays for confirmation and often genetic testing to identify the specific mutation. Additional investigations may include liver function tests, complete blood count, imaging studies, echocardiogram, sleep studies, and spirometry to assess disease extent. Here's our next clinical case. A 5-year-old child with MPS presents with increasing snoring, daytime sleepiness, and new-onset pulmonary hypertension. What is the most likely underlying cause? A. Primary cardiomyopathy. B. Obstructive sleep apnea. C. Restrictive lung disease, or D. Pulmonary glycosaminoglycan deposition? The correct answer is B. Obstructive sleep apnea. OSA is a common complication in MPS patients due to their short neck, macroglossia, adenotonsillar hypertrophy, and glycosaminoglycan deposition in upper airway tissues. Untreated OSA can lead to cor pulmonale and pulmonary hypertension. Sleep studies are essential for diagnosis. Management may include continuous positive airway pressure, adenotonsillectomy, or tracheostomy in severe cases. Other cardiopulmonary complications include restrictive lung disease from skeletal deformities and primary cardiomyopathy. Regarding neurological complications in MPS, which neurological complication requires regular monitoring? and may necessitate neurosurgical intervention in MPS patients. A. Peripheral neuropathy, B. Hydrocephalus, C. Seizure disorder, or D. Cerebral infarction. The correct answer is B. Hydrocephalus is a significant neurological complication in MPS that requires regular monitoring through head circumference measurements and neuroimaging. It results from glycosaminoglycan deposition in meninges and arachnoid villi, impairing cerebrospinal fluid circulation. Ventriculoperitoneal shunting is often necessary. Other important neurological complications include spinal cord compression from atlantoaxial instability, carpal tunnel syndrome, and cognitive impairment in most MPS types except Morquio syndrome. Let's discuss treatment options. Which treatment option shows the greatest benefit when initiated before age 2 in MPS 1 patients? A. Enzyme replacement therapy alone, B. Hematopoietic stem cell transplantation, C. Substrate reduction therapy, or D. Surgical correction of skeletal deformities? The correct answer is B. Hematopoietic stem cell transplantation shows the greatest benefit when initiated before age 2 in MPS 1 patients. When performed early, HSCT can preserve cognitive function by providing enzyme-producing cells that cross the blood-brain barrier. The typical treatment approach involves enzyme replacement therapy in the first 2 years, followed by bone marrow transplantation for eligible patients with MPS 1. Unfortunately, enzyme replacement therapy alone doesn't effectively cross the blood-brain barrier to prevent neurological deterioration. Let's consider our final clinical case. A 7-year-old child with MPS 4 or Morquio syndrome is being evaluated. Which finding would be least expected in this patient? A. Severe skeletal dysplasia, B. Normal intelligence, C. Corneal clouding, or D. Significant cognitive impairment? The correct answer is D. Significant cognitive impairment would be least expected in a patient with MPS 4 or Morquio syndrome. This MPS type is unique in that it preserves cognitive function despite causing severe physical manifestations. Morquio syndrome is characterized by severe skeletal dysplasia, normal intelligence, corneal clouding, extreme short stature, and dental abnormalities. Spinal cord compression due to atlantoaxial instability is a major concern requiring careful monitoring and sometimes surgical intervention. Regarding multidisciplinary care, which specialist is typically not part of the core multidisciplinary team managing MPS patients? A. Metabolic specialist, B. Orthopedic surgeon, C. Dermatologist, or D. Pulmonologist? The correct answer is C. A dermatologist is typically not part of the core multidisciplinary team managing MPS patients, as skin manifestations are not primary features of these disorders. The essential multidisciplinary team includes metabolic specialists or geneticists who coordinate care, orthopedic surgeons for skeletal issues, pulmonologists for respiratory complications, cardiologists, neurologists, ophthalmologists, ENT specialists, therapists, psychologists, and genetic counselors who provide comprehensive care addressing the multisystemic nature of MPS disorders. Let's discuss genetic counseling. What is the recurrence risk for parents who have had a child with MPS 3 or Sanfilippo syndrome? A. 0%, as it's a sporadic mutation, B. 25% for each pregnancy, C. 50% for each pregnancy, or D. 75% for each pregnancy? The correct answer is B. MPS 3 or Sanfilippo syndrome follows autosomal recessive inheritance, meaning both parents are typically asymptomatic carriers. Each pregnancy has a 25% risk of producing an affected child, 50% chance of a carrier child, and 25% chance of an unaffected non-carrier child. Genetic counseling is crucial for families, offering carrier testing for extended family members, prenatal diagnosis options, and pre-implantation genetic diagnosis. Note that MPS 2 has a different recurrence risk due to its X-linked inheritance pattern. Regarding prognosis and life expectancy, which factor has the greatest impact on improving life expectancy in MPS 1 or Hurler syndrome? A. Early enzyme replacement therapy alone, B. Successful hematopoietic stem cell transplantation, C. Aggressive management of skeletal complications, or D. Surgical correction of cardiac abnormalities? The correct answer is B. Successful hematopoietic stem cell transplantation has the greatest impact on improving life expectancy in MPS 1, potentially extending life from less than 10 years to 20 or 30 plus years. When performed early, HSCT can preserve neurocognitive function and reduce progression of many somatic manifestations by providing a continuing source of enzyme. Other factors affecting prognosis include the specific MPS type and severity, age at diagnosis and treatment initiation, presence of cardiac and respiratory complications, and access to multidisciplinary care. Regarding novel therapies, which emerging therapeutic approach shows promise for addressing the neurological manifestations of MPS? A. Modified enzyme replacement therapies that cross the blood-brain barrier. B. High-dose conventional enzyme replacement therapy. C. Mechanical valve replacement. Or D. Enhanced physical therapy protocols. The correct answer is A. Modified enzyme replacement therapies designed to cross the blood-brain barrier represent the most promising emerging approach for addressing neurological manifestations of MPS. Current conventional enzyme replacement therapy cannot effectively penetrate the central nervous system. Novel approaches include blood-brain barrier penetrating enzymes using fusion proteins or nanoparticles, intrathecal enzyme administration, gene therapy approaches, and small molecule chaperones. These innovations aim to overcome the limitations of current therapies, including limited CNS penetration and uneven tissue distribution. Here's our final clinical case. An 8-year-old with known MPS is scheduled for surgery. Which preoperative assessment is most critical for anesthetic planning? A. Liver function tests. B. Airway and cervical spine evaluation. C. Renal function tests. Or D. Coagulation profile. The correct answer is B. Airway and cervical spine evaluation is the most critical preoperative assessment for anesthetic planning in MPS patients. These patients present significant challenges due to difficult airway management from short neck, macroglossia, and narrow trachea, plus risk of atlantoaxial instability during intubation. A comprehensive preoperative assessment should include ENT evaluation of the upper airway, cervical spine imaging, cardiac assessment, and pulmonary function testing. MPS patients are considered high anesthetic risk and often require specialized protocols. Regarding family support, which of the following is most important in long-term management of families affected by MPS? A. Financial planning resources. B. Psychological support and counseling. C. Home healthcare equipment. Or D. Dietary management. The correct answer is B. Psychological support and counseling are most important in the long-term management of families affected by MPS. The chronic, progressive, and multisystemic nature of these disorders creates significant caregiver burden and impacts family dynamics. Comprehensive support should include regular psychological assessment and counseling, connection to MPS support groups, educational resources, respite care options, and school liaison services. While financial planning, home healthcare equipment, and dietary management are important, the psychological well-being of patients and families is fundamental to quality of life. Regarding school and community integration, which accommodation is typically most beneficial for a child with MPS in the school setting? A. Individualized education plan with multidisciplinary input. B. Homeschooling with specialized tutors. C. Shortened school days. Or D. Standard classroom setting with minimal modifications. The correct answer is A. An individualized education plan with multidisciplinary input is typically most beneficial for children with MPS in the school setting. This approach provides tailored educational strategies based on specific needs, appropriate accommodations for physical limitations, and integration of necessary therapies. School considerations should include physical accessibility modifications, emergency medical protocols, staff education about MPS, and social integration support. The optimal approach balances inclusion with specialized services to address the child's evolving needs as the disease progresses. Thank you for joining this comprehensive lecture on mucopolysaccharidosis. We've covered the genetics, pathophysiology, clinical manifestations, diagnostic approaches, and management options for these complex disorders. Remember that early diagnosis and multidisciplinary care are essential for optimal outcomes. As new therapeutic approaches continue to evolve, there is increasing hope for improved quality of life for patients with MPS. Please follow Pediatric Case Review for more informative presentations on rare pediatric conditions. If you have any questions or topics you'd like to see covered in future lectures, please leave a comment below. Thank you for your attention.